Okay, so let's talk about acute abdominal pain. So when we think of acute abdominal pain, we're usually thinking of pain that's occurred usually with a relatively rapid onset, not something that you've had for weeks to months. So it's come on acutely. Um, and often it can be severe abdominal pain too. So new onset abdominal pain. And there's many causes. We'll come to them. We'll break the abdomen into 4 different quadrants, maybe a few more, and talk about the conditions in those different quadrants, okay? So figuring out what the pain is often a challenge in the abdomen. So we try and get as much description of the pain and the symptoms that are associated with the pain. So what's the pain like? Is it crampy? Is it sharp? Um, does it radiate anywhere? Is it associated with anything such as nausea or vomiting or diarrhea or vomiting blood? Anything that might be associated with the pain. Does it hurt to urinate? Do you have blood in your urine? Do you have fevers? So as you ask more and more questions about the onset of the pain, the type of the pain, the location of the pain, any associated symptoms along with this abdominal pain, it really starts to narrow it down. At the beginning, it's a bit difficult to see all that, but it really does help narrow it down. Someone's position while they're lying in front of you. So if you have something like peritonitis, you're sick, and that peritoneum, which is like a saran wrap lining the bowel, does not want to be moved. So you're going to lie and not move. Okay? So you may be lying on your side, fetal position, but the key here is you're just not moving. You don't want to stretch that peritoneal lining and cause more pain. Um, Supine pain. So, I mean, this is hard to kind of say, well, you'll definitely be lying down if you have visceral pain, which is organ pain. Not necessarily. But let's go to the next one and we'll see if we can make some sense of this. So, restless pain. So, someone who's pacing back and forth in the waiting room. That's usually something that's suddenly become blocked. Okay, so what can suddenly become blocked? How about a kidney stone in your ureter, or a gallbladder stone in your cystic duct, or a bowel obstruction that suddenly blocked your bowel, or acute urinary retention from a blocked prostate gland? They're not sitting down; they're pacing. They're going back and forth, right? Something has suddenly blocked, and they're extremely uncomfortable. So 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 restlessness can really help you. They just can't sit still. They're so uncomfortable. Um, Radiation can definitely help you. Like, where does the pain go? Does the abdominal pain go to your back? Does it go to one of your shoulders? Does it radiate into your groin? Is it flank pain as opposed to abdominal pain? Uh, Nursing assessments, we definitely want to know vital signs. If someone has low blood pressure, or they're tachycardic, or their O2 saturation is low. Hypovolemia can definitely be an indication or a concern that might lead us to think that someone's bleeding internally from an ulcer or from some other source in their gastrointestinal tract. Temperature, for sure, we'll suspect infections much more, whether it's a pyelonephritis in the kidney or some kind of cholecystitis, infected gallbladder. So temperature will help. Usually we save the palpation for last. Okay, so we look at the abdomen. We want to see if it's distended. Is it discolored? Is there any abnormality of the skin? Is it yellow, such as in jaundice? And then we'll listen to the bowel sounds. to see if there are bowel sounds and the quality of the bowel sounds, whether they're tympanic. Tympanic bowel sounds like the sound of a drum. It sounds very echoey. That's usually an indication of a bowel obstruction. And then we'll palpate last. Okay, and we'll go around and palpate the different quadrants of the abdomen. Okay, we're getting close to the end here. Acute abdominal pain conditions. So we often will break up the abdomen into quadrants so that we can have, just in our mind, we can process a bit more and think about the more likely diagnoses that are happening and the conditions that tend to occur in those quadrants. So you can see there's 4 quadrants. Actually, there's 6, because if you look on the right side, there's epigastric and periumbilical. So let's just go through a couple of these. So right upper quadrant. What lives in the right upper quadrant? Well, the gallbladder lives there. So you could have an infected gallbladder, cholecystitis. The right kidney lives there. So you could have a pyelonephritis, which is an infection of the kidney. You could have a kidney stone stuck in the ureter, giving you pain. So renal colic or a ureteric colic. You could have hepatitis, so inflammation of the liver. And often, don't forget, you wouldn't just have right upper quadrant pain with some of these, right? Hepatitis, you'd have jaundice, you would have clay color stools. It would be a whole constellation of symptoms, and that's how we tease apart the different ones. Pneumonia. Surprisingly, the lungs come down quite a bit, more than you would think on a chest. So a right lower pneumonia can give you right upper quadrant pain. What about right lower quadrant pain? So appendicitis, the appendix lives down there. Still again, renal colic, a ureteric stone in the ureter can give you right lower abdominal pain, since we're on the right side. It can give you right flank pain. It can give you pain that radiates right into your groin, or if you're a male, a testicle. A hernia can give you some lower abdominal pain, right or left. Inflammatory bowel disease. Remember, Crohn's disease typically affects the distal ileum most frequently, can affect anywhere. So that could give you right lower quadrant pain. A UTI, that's usually lower central abdominal pain, right over the bladder. For some reason they listed it there. That's fine. So a bladder infection typically gives you lower central abdominal pain, burning on urination, frequency, you're going to the washroom all the time. But remember, a bladder infection would never give you a fever. Gynecological diseases. So an ovarian cyst can give you, depending on which side it's on, right or left, lower abdominal pain. PID, which is pelvic inflammatory disease, which is an infection of the fallopian tubes. That can give you right or left lower abdominal pain, depending on which tube is involved. How about ectopic pregnancy? So a tubal pregnancy can give you right or left lower abdominal pain in a female. A twisted testicle, testicular torsion. In children, they might present with lower abdominal pain as opposed to scrotal pain. So if we go to the left lower quadrant, a lot of them are similar because we have 2 of many things. So testicles, ovaries, we have 2 of many things. Inguinal hernia is the same. You can have renal colic on that side. Diverticulitis. So that's a condition we're going to come to. Much more common in the left lower quadrant of the large intestine. And we'll come to that condition. What about central abdominal pain? Periumbilical. Well, those are your bowel obstructions, right? So you're getting a lot of distension and bloating. So in bowel obstructions, you typically have periumbilical abdominal pain. Appendicitis often starts in the periumbilical area and goes to the right lower quadrant, so we'll talk about that. An aortic aneurysm is an enlargement of the aorta that gets bigger and bigger and bigger as time passes. Like when I say time, I mean usually years. And finally, it can rupture. And that can give you severe abdominal pain that radiates to the back. And of course, your blood pressure is sinking fast because you're losing all your blood from a ruptured aortic aneurysm. What about epigastric pain? Well, there's a lot of things packed in the upper abdomen. So peptic ulcer, whether it's a gastric or duodenal ulcer, cholecystitis, so that gallbladder's back, that can give you some epigastric pain. It doesn't have to be on the right side. Pancreatitis lives right in the epigastric area. That's often pain in the epigastric area that goes to the back. Myocardial infarction can present with epigastric pain as opposed to chest pain. And finally, I'm not sure if we did the left upper quadrant, but you'll see that some of them are quite similar to the right, although the stomach's on the left, so you're not going to get, so you'll get more stomach type symptoms, gastric ulcer, dyspepsia. But you have a kidney there, you have, you can get a pneumonia on that side, so this just helps break it up a bit. Okay, so let's just talk about referred pain a bit, the concept of referred pain. So it's pain that's felt away from the actual disease process that's taking place. So I have some examples here. So cholecystitis, which is inflammation and infection of the gallbladder from a blocked cystic duct from a gallstone, is referred to the right shoulder. So not only do you have right upper quadrant pain, you can also come in and say, my right shoulder also hurts with whatever's going on. So what I was saying before is it's usually a constellation of symptoms that really helps narrow down what's happening. So, you know, again, in cholecystitis, you have right upper quadrant pain, you have fever, you're often vomiting, you're nauseated, you might have right shoulder pain. So you can put things together a bit more as you go along. Okay, how about cardiac pain? Well, ischemic chest pain from the heart, so angina or an MI, that's often referred to the left shoulder or the right shoulder or the jaw or the epigastrium. Sometimes it goes through to the back. So it's referred all over the place, okay? How about gastric pain? So stomach pain is often referred to either the umbilicus or the epigastric area. A kidney stone. So if you're passing a kidney stone, you can feel pain all the way down into your groin and your testicles if you're male, or just your groin if you're a female. And that's referred pain. Okay, so it has to do with the nervous system as well, where the nerve fibers are being referred to, or what's innervating at the diseased area, and also where those nerves are traveling to. So appendicitis often starts as umbilical pain, so periumbilical pain. And then later, 4 to 6 hours later, it migrates to the right lower quadrant. Okay, so here we are with appendicitis. So symptoms and signs of appendicitis. So remember, appendicitis is usually a disease of puberty time, you know, the 12 to 15 age group. It can happen in early childhood and it can happen in an old person, but it's usually around puberty, okay? And you often start with central abdominal pain, so that periumbilical pain. You often have, you can have some low-grade fevers. You can be nauseated and start vomiting. You often have no appetite. You just don't even think of eating anything. You just complete loss of appetite, which is anorexia, it's called. So you're anorexic. And then typically after 4 to 6 hours, it migrates and localizes to the right lower quadrant. Now, how often do you get a perfect story like that? Very infrequently. I think a classic presentation of appendicitis is typically less than 10% of the time. So we don't get that perfect description very often. There's a couple of signs that might help you with the diagnosing or figuring out if it's appendicitis. So Robson's sign is where you press in the left lower quadrant, and when you press there, they tell you that it hurts in the right lower quadrant. So the reason why this happens is when you're pressing in the left lower quadrant, you're actually stretching the peritoneum. And when you stretch the peritoneum, the part that's going to hurt is the part that's inflamed. And that is the right lower quadrant. McBurney's point is the exact location that we measure from the umbilicus to the anterior iliac crest. Look at the bottom diagram there. And McBurney's point is the typical location of the appendix. Okay, so that's just a fact, just a information point there. You can often have an elevated white blood cell count in appendicitis, so that can sometimes help. Rebound tenderness is where we press into an area, and when we let go, it hurts even more. And it's the same idea of when I press in slowly, I am stretching the peritoneum, but very slowly. When I let go fast, the peritoneum stretches fast around the inflamed area, and it hurts even more. Okay, so you can have rebound tenderness in appendicitis when you press over the right lower quadrant. And some appendicitis, if you've had it for 24 to 36 hours, they can perforate and lead to peritonitis, which is not an outcome that anybody wants, because that's a much more complicated scenario now. You're much sicker. There's a much longer recovery period. So we try to catch appendicitis before it perforates and causes peritonitis. Okay, so let's look at a couple of clinical exam tests that can be done to see if it elicits pain when you do certain maneuvers of the leg. So the first one is the psoas sign. So the psoas muscle is a muscle in your back, and the appendix is right in front of it. So by extending the hip backwards, if it gives you right lower quadrant pain, then that's an indication that you may have appendicitis. So a positive psoas sign. The obturator sign is where you flex the hip and the knee, and then you rotate the flexed hip. And what that's trying to do is see if you can irritate the appendix with this maneuver. So that would be a positive obturator sign. So psoas signs and obturator signs, they're not terribly sensitive or specific, but we sometimes use them to see if we can bring on the right lower quadrant pain or aggravate it more, which may lead us a bit more to think that it's appendicitis. Okay, so let's do this slide on appendicitis. As mentioned before, typically it's around puberty that most people will get appendicitis, although you can get it at any age. You can be a young child or you can be an older person, but typically it's around 10 to 14 or 15. And it usually begins as a a central abdominal pain, periumbilical pain, that then progresses to the right lower quadrant over the span of 4 to 6 hours. And often you have associated symptoms with it. So you can have a low-grade fever. You don't have to have all of these, by the way. Some people will have nausea, anorexia, so loss of appetite is a big one. So, often I'll ask a child, "What's your favorite meal?" And when they tell me, I'll ask, "Would you have some now?" And if they're really anorexic, they say, "No, I wouldn't want to eat anything right now." So that's a big symptom. Often there'll be, for diagnosis, well, it's the clinical signs for sure, right? So this description of central abdominal pain migrating to the right lower quadrant, some vomiting, nausea, low-grade fevers, anorexia. And then we'll often do some blood tests if we suspect appendicitis. Sometimes we'll see an elevated white blood cell count, which indicates an infection. We'll try and diagnose it with a ultrasound to avoid any radiation by avoiding a CAT scan. We can't always see it with an ultrasound though. So then the next step would be either a CAT scan, accepting the radiation dose that the young person will get. And this isn't done very commonly anymore, is just to diagnose clinically the appendicitis and then to go straight to surgery to remove the appendix. That was done decades ago. Most surgeons want to see some evidence of appendicitis on either an ultrasound or a CAT scan. So let's just look at a couple of, so McBurney's point we mentioned, that's just the exact location of where the appendix lives. The rebound tenderness is when we press into the right lower quadrant, then let go suddenly. The patient says, "That really hurt when you let go." And again, that's the stretching of the peritoneum when you suddenly let go. Okay. Most of these patients if we suspect appendicitis, we're not going to give them anything to eat or drink until we've done some imaging with an ultrasound or a CAT scan. And if it shows an appendicitis, then they won't be having anything to eat or drink until after the surgery. If the appendix ruptures, which is an unfortunate complication because now you have peritonitis, that's a much more prolonged illness. Not only does the appendix need to be removed, but they're often on IV antibiotics to clear the appendicitis.